ECMO and CRT. Let's start. So, first of all, we discuss the effects on the pharmacokinetics on ECMO. So, there are main three determinants which we discuss. The first is drug sequestration, second is altered volume of distribution, and third is altered clearance. So, on ECMO, the changes in pharmacokinetics mainly depend on the two determinants, volume of distribution and drug sequestration. The altered clearance is mainly we see with the CRT because the ECMO itself is not a dialyzer. So, in volume of distribution, the drugs which have less than 1 liters per kg are mainly hydrophilic. The expected change in the volume of distribution of these drugs is moderate to large increase, and for this we have to increase our loading dose. The second category is the drugs which have volume of distribution more than 1 liters per kg. So the expected change in the volume of distribution of these drugs is minimal, and so for that we have no increase in loading dose. The second modality is the drug sequestration. Drug sequestration depends on the two properties of the drug, the lipophilicity and the protein binding. The lipophilicity, how we calculate the lipophilicity? Lipophilicity mainly depends on the log P value of a drug. So this is the partition coefficient. So the value of less than 1 is low lipophilicity, and mainly the drug is hydrophilic in this value. From 1 to 2 is moderate lipophilicity of drug, and for more than 2 is highly lipophilic drugs. Same is with the protein binding. Less than 30% is low protein binding, 30 to 70% is high protein binding, and more than 70% is high protein binding of the drug. So here the volume of distribution is the apparent volume that tells us how widely a drug spreads outside the plasma. And the sequestrations mainly the loss of the drug to artificial surfaces of the compartment of ECMO, mainly the circuit, filter, tubing. So if we see the log P value of less than 1 of a drug with a minimal less than 30% protein binding, so sequestration is minimal, and in this minimal sequestration we have no maintenance dose adjustment. Similarly, on the other side, if the drug has a higher lipophilicity, more than 2 log P value, with a high protein bindings, more than 70%. So in that case, high sequestrations will occur and increased maintenance dose or increase in the frequency or rate of drug required. So moving to our next page. Here we see the interrelationships between the lipophilicity, hydrophilicity and protein bindings and their impact on critical illness and ECMO on drug pharmacokinetics. So 4 categories, 2 for hydrophilic and 2 for lipophilic drugs. The hydrophilics with low protein binding and high protein bindings, the first 2. So for low protein bindings, little absorption or low drug sequestration is there, but the volume of distribution is high due to priming dilution of the ECMO circuit. Second, the hydrophilicity and high protein binding drug. Mainly examples are ceftriaxone, teicoplanin. In the ECMO, there is moderate sequestration is there due to bound fractionistics. Third category is, third and fourth are lipophilic with low protein binding and high protein binding. For both moderate sequestration to maximal sequestration is there because of the property of lipophilicity. So to summarize this, the mainly the increase in the volume of distribution with yellow in color. So this increase in volume of distribution mainly decreases the plasma concentration, and the increase in the volume of distribution occurs due to high volume resuscitation in critical patients, hemodilution due to priming of the circuit, drug sequestrations, leaky capillaries in critically ill patients, and drug analysis. Similarly, the increase in plasma concentration occurs due to decrease in the clearance. Decrease in clearance in ECMO patients with critical illness mainly occurs due to renal and hepatic hypoperfusion. So moving onto the literatures we have mainly for ECMO we have mainly the ex vivo and animal studies. So moving to our literatures, these are very good studies. The ASAP ECMO study group, they had studied a lot of medications kinetic wise in this study. Not only the antibiotics, they also studied other drugs like sedatives using in the ICU in the patients on ECMO. So we will focus here the antibiotics and their drug dosing studies in the patient on ECMO. Another literature, ex vivo model for the describe the impact of ECMO on beta lactams degradation. So the conclusion is on sequestrations by ECMO tubings and drugs. Significant loss of beta lactams, cefotaxime was observed in this study, and ceftriaxone concentrations remains unchanged as the ceftriaxone is hydrophilic, low volume of distribution is there, and moderate decrease in concentration of cefazolime, cefepime, and piperacillin was there. Another literature for cefepime pharmacokinetics in adults on ECMO, the conclusion is patient on ECMO has a lower free concentration minimum and MIC ratio. It is because of high volume of distribution of primary fluid plus moderate sequestrations, which results in the lowering of free plasma levels despite of standard dosing of cefepime. High risk ECMO patients have high treatment failure rates and poor outcomes. So more aggressive empiric dosing may be warranted to optimize exposure when treating infections due to pathogens with high elevated MIC. Another literature on changes of cholesterol pharmacokinetics in critically ill patients due to extracorporeal membrane oxygenation. So mainly the cholesterol and cholesterol sodium are hydrophilic plus low protein binding. So little to no sequestrations in ECMO circuits for the cholesterol. So conclusion of this literature is no cholesterol sodium dose adjustment needed for ECMO patients. These are some antimicrobial dosing strategies in patients treated with ECMO with or without RRT. So the initial dose, use a high initial dose, especially in patients already on ECMO plus minus RRT. Take into account patient's body weight, especially for vancomycin dosing. Do not reduce dose based on renal functions. Loading dose is mandatory before starting a prolonged or continuous infusion. For early maintenance dose or day 1 or day 2, optimize treatment modalities, that is the prolonged and continuous infusions for beta lactams and vancomycin patient. Do not estimate renal functions. Use measured creatinine clearance in 8 hours and 24 hours time during collection. Here, 8 hours is more accurate than as compared to 24 hours. Dose adjustments in patients with AK, doses of non-toxic antibiotics like beta lactams should not be reduced during the first 24 to 48 hours. Dose of toxic antibiotics like vancomycin and colistin should be reduced based on dosing tables. Maintenance dose adjustment in patients with CKD, dose reduction based on residual renal function. Consider increase in maintenance dose in case of augmented renal clearance. Augmented renal clearance is when the measured creatinine clearance is more than 130 ml per minute. In the late phase, late maintenance dose from day 2 onwards, adapt the dose based on residual renal functions, monitor plasma exposure based on therapeutic drug monitoring. Consider to increase dose in case of reduced susceptibility, adapt dosing or apply therapeutic drug monitoring when changing in RRT modalities or ECMO circuits or ECMO distribution. These are some guidances from Northwestern Medicine Antimicrobial ECMO. So for non-beta lactam, vancomycin, the protein binding is moderate in the low log P values, minimal to moderate sequestration. The recommendations are treatment loading dose 20 mg per kg, maximum dose of 2000 mg. Prophylaxis dose, no loading dose is indicated, standard maintenance dose is indicated, and recommend therapeutic drug monitoring. Here the therapeutic drug monitoring, for vancomycin we use AUC guided therapeutic drug monitoring. What are the targets of the AUC by MIC for vancomycin is 400 to 600. Here we do not rely on trough levels because in these patients, in critically ill patients, it is misleading due to variable clearance. So, Meropenem, low protein binding, low log value, minimal sequestration, but volume of distribution is high, so aggressive dose is needed. And use extended infusions, consider TDM, especially in documented cases of infections or renal dysfunction patients or on CRRT. Other fetal items all have almost low protein binding and low log P values, so minimal sequestration is there and standard dosing is recommended. For lansoprazole, protein binding is moderate, minimal to moderate sequestration, standard doses are recommended, or consider alternative or 600 mg 8 with TDE. Piperacillin tazobactam, moderate protein bindings, low log P values, those are on aggressive ends, use extended infusions as other fetal items. So moving on to antifungals, we need to keep in mind that whether it's volumes or echinocandins or triazoles except fluconazole, all have high protein binding properties and fluconazole is low protein binding. So first, liposomal in comparison, high lipophilicity drug, so moderate to high sequestration. So dose on aggressive and 7 to 8 mg per kg per day or considered alternative like DHC and consider 10 mg per kg concerns of clinical failure is there. Deoxycholic amphotericin, high protein binding, low log P value, moderate sequestrations, drug on aggression and 1 mg per kg per day. For fluconazole, it is low protein binding and low log P value, so minimal sequestrations is there. So consider increasing only the loading dose and standard maintenance dose is recommended. Other azoles, moderate protein binding, moderate to high sequestrations, consider the extended loading doses and TDM after 3 days. Microfungin, high protein binding, moderate sequestration, the recommended dose is 200 mg once a day. Summary for pharmacokinetic changes and potential dosing adjustments for sedatives and analgesics during ACMO. Almost all the categories of sedatives and analgesics, benzodiazepine, dextromethorphan, opioid, and propofol, they are almost all have high log P values except morphine and moderate to high protein binding. So higher initial doses with higher daily doses should be considered. Moving on to CRRT. Dosing complexities in patients on CRRT depends on again the 3 factors which we have discussed. Some of them we have discussed already. Patient, drug, and RRT factors. Patients have volume of distribution, renal residual functions, and hypoalbuminemia, weight, drug, molecular weight, hydrophilicity, lipophilicity, and protein binding of the drug. The RRT factors, RRT modalities, RRT setting, absorption of filter lifestyle. So the phases: absorption, distribution, protein binding, metabolism, excretion. Absorption, as in critically ill patients, we do not use the oral medication, so it can be excluded. Distribution, high volume of distribution in sepsis and fluid overload patients. So we have to give full and high loading doses for hydrophilic drugs especially. Protein binding, low protein albumin levels, so it increases the free bound unbound drug, which increases further the clearance, and high volume of distribution drugs here are more rapid. Metabolism, decreased hepatic flow and variable enzymatic activity, watch for accumulation of drug and practical impact, watch for accumulation of drug and reduced clearance of excretion. If the native renal function decreases, CRRT also adds extracorporeal clearance. So maintenance dose depends on CRRT setting and the problem. Similar table like ACMO, relationship between lipophilicity and the hydrophilicity and protein binding. So in CRRT, the first category, hydrophilic and low protein bound, high clearance due to small size and free water soluble drug. So maintenance dose should be increased or shortened drug. Second, high protein binding hydrophilic, normally low clearance is there, but if albumin is decreased, so unbound fraction is increased, so more drug is removed. Lipophilic, low protein binding, minimal clearance, large volume of distribution, and tissue and lipophilic with high protein and negligible CRT clearance. CRT basis that drive the dosing. So mainly the three main modalities, the CVPH, continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, and continuous veno-venous hemodiafiltration. So CVPH uses the convection method, CVPHD uses the diffusion, and CVPHDF both convection and diffusion methods. So in this, the approximation of clearance from the CRT depends on this equation, where the SC is the sieving quotient, which is mainly in the convection method used. Fraction of the plasma, it is the fraction of the plasma that crosses the membrane in the ultrafiltrate in convection, and the QUF is ultrafiltration flow across the membrane. It is in milliliters per hour, and the SA is the saturation quotient, which is mainly takes in the diffusion part of the CVPHD. Fraction of plasma concentration appears to the dialysis at steady state. So, this is the equation, and the intensity according to PIDCO guidelines, the target delivered effluent rate should be 20 to 25 ml per kg per hour in adults, and the higher effluent rates increases drug removal only, but the clinical outcomes will not improve. And the interaction matters, so the clotting time or downtime markedly reduce the drug removal. It is normally around 20 to 25%. So avoid unintended accumulation. So the therapeutic drug monitoring, a quick guide for therapeutic drug monitoring, which we have to do. In vancomycin in serious MRSA patients, the AUC by MIC current targets of 400 to 600 is there, and this TDM in AUC by MIC measures by pricing software, where we have to enter the data like patient details and creatinine, serum creatinine levels, and it is mainly drawn 1 to 2 serum samples at any reasonable time within the first 24 to 48 hours. And avoid trough levels only targets unless correlated to AUC on your platform. This is because the trough levels are basically not reliable in high clearance. Beta lactams, for beta lactams is available target 100% of free fraction time more than MIC. In critical areas, we have a target of 4 times of MIC. Use extended infusions and continuous infusions to optimize. Azoles, for voriconazole, C minimum is 2 to 5 milligrams per liter. For posaconazole, C minimum is more than 1 to 1.25 milligrams per liter. Fluconazole, PDM is usually not needed. For linezolid, watch for underexposed on high CRT effluent. Consider TDM is prolonged therapy. For cholesterol, measure plasma concentration cholesterol after 48 hours of steady state, and just before next dose or average concentration if possible. The target concentrations for cholesterol therapeutic window is 2 to 3 milligrams per liter. So the CRT dosing thumb rules: give full doses, adjust maintenance doses by effluent rates, prefer extended continuous infusions for time-dependent beta-lactam antibiotics, and use TDMs as we discussed in the last slide. Dosing adjustment in CRT unnecessary if antimicrobial range is already physiologically less than 25 to 30% of the total drug clearance. High protein binding drugs like tigoplanine, guanidinium, and amphotericin, and lipophilic. These are CRT antimicrobials. Practical dosing by effluent rate for 1 liter per hour effluent rate or 2 liters, 3 liters for all beta-lactams and cyclopamines. We have like 600 mg Velarde for 1 liter. For all mostly we have to consider the TDM possible. And in antifungals, the amphotericin B, the deoxycholate and liposomal, in in ECMO only settings, the standard dosing, no change in the standard dosing in deoxycoded amphotericin B, or for liposomal amphotericin B may require to increase the dose, maybe doubling of the dose if low levels observed, and TDM is helpful in this. For CRRT only, use standard dosing, minimal removal due to size and protein binding of amphotericin. And standard in liposomal standard dosing, CRRT has limited impact due to size. For prostatic dosing recommendations in patient on ECMO CRRT or both, for CRRT, the loading dose should be 9 milliunits. Maintenance dose is increased to 13.5 million units per day. Dose adjustment on for dialysis clearance. For ECMO only, no CRRT, standard dosing loading and standard maintenance, as we have discussed earlier. And as the renal function improving, we assess the dose for loading dose and adjust based on clearance and monitoring for maintenance dose. ECMO plus CRRT together step-by-step approach give full loading dose, assume increased volume of distribution in critical illness plus circuit. Choose maintenance dose for CRRT tables by equivalent rates. Prefer extended and continuous infusion for beta lactams. For vancomycin, we have to take prophylactic TDM levels 24 to 48 hours, and for azoles, day 3 or 4. Reassess after any separate change, CRRT downtime or rising clearance lactates or ordinary. Take-home messages are the same. ECMO mainly increases the volume of distribution, sisters, lipophilic and protein bounding drugs, load free, favor TDM, CRRT clearance tracked by equal rates, and use prolonged infusions for especially for beta lactams, AMC guided, recheck after circuits, and TDM and plus maintenance on beat stuff, fixed tables.
Thank you, Dr. Apul, for a insightful and comprehensive lecture. Although it's complex.
Extracorporeal therapy is an excellent therapy for reducing mortality and improving outcomes in sepsis. Thank you. Sorry about that. Sir William Osler, in his essay on evolution of medicine, way back in 1904, said, except on few occasions, the patient appears to die from the body's response to infection rather than from it. So the patient is not dying because of the infectious disease load, the bacteria or the virus. He is dying because of the physiological consequences of the infections, which could be hemodynamic instability, which could be high pH ratio, which could be anything. So we have to target the physiological disturbances rather than the basic. The goals of this presentation are to understand the role of extracorporeal therapy in sepsis, why we need it, the clinical basis, clinical settings to use extracorporeal therapy, how to use it judiciously, and what does the future hold for extracorporeal therapies if at all. Sepsis is thought to be a graveyard of clinical research in terms of adjuvant therapies, not routinely. The search for holy grail for diagnosis and treatment is on, but we will never have a holy grail because we do not have any holy grail for any disease. Today, none of these novel therapies have improved patient outcomes. Will we have something like a holy grail which will improve the outcome with a single drug or intervention? The answer is no. In the era of evidence-based medicine, extracorporeal therapies have gone to prove the efficacy. However, absence of evidence should not translate into evidence of absence. One plausible explanation for this apparent failure of all these adjuvant therapies, especially on big data analysis, the heterogeneity across patients fulfilling the diagnostic criteria. We have a huge class of patients which are in sepsis or septic shock, and we are trying to solve the problem with a single solution which can never happen. The entire journey of sepsis for 50-60 years has been about magic bullets, but now we are wiser, especially after COVID. There are no magic bullets. For every complex problem, if there is an answer that is clear and simple, it is wrong. So if we venture into these therapies thinking that this will solve all our problems, we are essentially wrong from the beginning. So do not think that any of these interventions are going to solve the problems. This was said by an American journal long back. Don't fire until you see the white of their eyes. So you must have sound clinical basis for any therapy before you venture into it. And you must see some clinical benefit. It could not be mortality benefit, but there should be some clinical benefit. We already discussed the scenarios where extracorporeal therapies could be used in sepsis. Initially, we thought there are two phases of sepsis, the SIRS phase or CARS phase. This was the serial biomarker hypothesis. Another one is parallel. Both things are happening. SIRS and CARS is happening in parallel. How does this happen in an individual patient? We still do not know. Sometimes it happens fast. And there are no fixed timelines that this biomarker will appear first, this mediator will appear first. It's very, very complex. We have only minimal understanding. However, initially it was thought these extracorporeal therapies and adjuvant therapies have a major role in the pro-inflammatory phase. But mortality which is happening in the CARS phase also. So, the usage of these extracorporeal therapies are not limited to the pro-inflammatory, the red one, but also extended to the CARS phase because there is a lot of mortality, organ disruption, secondary infection happening in the CARS phase also. More organ failure actually happens in the CARS phase, but it goes unnoticed and it is a chronic organ dysfunction. And this is most of in a prolonged phase. If it is a prolonged phase, it will obviously lead to more mortality. So the usage of extracorporeal therapies and other adjuvant therapies have been extended to both the phases. You cannot stop the waves, but we must learn how to serve the wave. This is all about immunomodulation or immunohomeostasis or bringing the patient to a lesser degree of immune disarray. This is our target in sepsis because now we understand by definition sepsis is an immune-mediated disease secondary to infection. So we must target immunological targets while we treat sepsis. This is the basis of the trident theory of treatment of sepsis. Antimicrobials obviously are the mainstay. Immunomodulation, whether it is steroids, whether they are extracorporeal therapy, are the second major arm. And multi-organ support therapy, what we all do in our ICU, oxygen therapy, replacement therapy, and other things is the third arm. Immunomodulation, the largest amount of evidence and the only reasonable amount of evidence is with steroids for septic shock. Other modalities of immunomodulation do not have any evidence. Why we fail with all these adjuvant therapies? No quick fix solution because sepsis is a very, very complex problem. Most of the time we are targeting non-immunological targets and we are doing monoclonal therapies, anti-TNF antibody, IL-1 receptor antagonists, things like that. That is why we are failing again and again. And there are many mediators of sepsis. If you block one particular arm, other arms will take over. There is redundancy. You stop one arm, other arms will take over. And these mediators of sepsis, although we call some as pro-inflammatory, some as anti-inflammatory, but they have dual role. They might be having some good effect, some bad effect, and some ugly effect. So we have to balance which one to remove and how much to remove. And we understand very few of the biomarkers or the mediators. 300 of them we know, there might be thousands and thousands more. Septic shock is again an entity which is defined by higher mortality. So if we include septic shock in most of the trials, the outcome becomes even more poor, more so with extracorporeal therapy. So plugging all the categories of sepsis is judicious for trials as well as in practice, but we have to individualize. especially when we think about these broad-based therapies like extracorporeal therapies. Trigger to therapy for extracorporeal therapies remain unclear. What phase of disease we could initiate? We must be guided by biomarkers or biomediators. That is why we talk about theranostics. While tolerating was launched, we use endotoxin activity assay to guide our therapy along with clinical picture. We are not treating numbers, we are treating patients, so we have to look at the clinical pictures. Genomic
iPhone
codes
का
are
सकता हूँ।
better predictors, we still require, and we need better endpoint of